Are you performing death rituals or resuscitations?
Let's talk about it. So, if you haven't seen this video, you need to go watch the video. As always, the EMS Avenger has put out a very thought provoking video. And if you have watched me at all, even briefly, you know that I am very opinionated about resuscitation. I literally have a video on epipulses and transport time and all of that. So, if you're interested in that, please go watch it. Now, outside of that, right, I am also opinionated about resuscitation because I am an end of life doula. And I see things from not only a pre-hospital practitioner standpoint, I also see things from a end of life doula standpoint. So a support of the person that is dying and the support of, trying to prevent the total death of a patient. And those two things are kind of oxymorons, right? Because when I am practicing medicine, as a pre-hospitalist, I am practicing with the intent of saving a life, right? When I am working as an end of life doula, my job is to support that patient during their death. And what I think needs to happen personally, especially when it comes to, resuscitation and how we work it right now, which, you know, we need to be having the conscious awareness that our job is literally to support this person that is dying. Now, we work, like in the pre-hospital setting, we work with the understanding unless that patient has a DNR, they do not want to die. I agree, right? Unless that patient has a DNR, they do not want to die. So I'm going to do everything within my power to make sure that they don't die. But another thing that I'm going to be doing that I think a lot of people don't put into the forefront of their brain is that I want to have a favorable patient outcome in the long term also. So that means I'm going to, if I have a big enough team of people, I'm going to be getting their medications, right? I want to know what they're on, not only because maybe it'll tell me why they're down, but it can also tell me how to best support them with the medications that I can push pre-hospitally, right? Especially if I get ROSC to bring out a more favorable outcome for that patient in the long term. Now, where I come from originally, we call that a clinical save. And that means that that patient has survived outside of the ICU for greater than 30 days. And I personally think that that should be everyone's goal. Not to get a clinical save, not to get a high five for that person staying alive. It's because we should be thinking about, am I keeping intact their neurological function? Now, obviously, you can't predict that per se, especially if it's not a witness downtime. So that one's like, okay, yeah, sure, maybe I'm protecting their neurological function. But am I supporting this patient during the time in which I am with them, right? And they're in cardiac arrest or they're on new onset ROSC, right? Because we know that once we get ROSC, this is now a new patient. And so we should be supporting that patient as if we have just met them. And if I just meet you, this is the rhythm that I have. And I am not just looking at an EKG, I'm not just looking at a 12 lead for like a couple minutes and making a decision. No, I'm printing out multiple 12 leads, or I'm watching this 12 lead go on with succession because I want to know what rhythm are you consistently in. And if you're in a consistent rhythm, can I then support that rhythm to get better? Or can I bring you into a better rhythm? Outside of that, right? What is your oxygenation status? Are you perfusing effectively, right? And if you're not perfusing effectively, is there something that I can do in the pre-hospital setting to make sure that you are better perfusing, right? And I'm going down these boxes because I want a more favorable patient outcome in the long term. I want to protect that neurological function in the long term. And especially when it comes to witness arrests, a lot of the time we take these 20 minutes, these 30 minutes, and we work it, we work our algorithm, and then we're like, oh, 30 minutes, now we're done, right? Or because, you know, unfortunately, we have some people who don't understand what happens during an arrest. We get chirped in the middle of an arrest and they're like, what's taking so long? Like, I'm trying to make sure this person doesn't like stay dead. I'm trying to get them to the hospital and get them to a point in which they can survive. Now, am I going to say that back to dispatch? No, I'm going to be like, hey, I'm busy. You know, I'm still working this arrest. And, you know, if it's really that bad of an arrest, sometimes your supervisor comes out. If you're lucky enough and you've got a jump car and, you know, you get your, medical director who is involved in, you know, patient care, they come out, you know, it's a whole thing. And also, if you work in EMS long enough, you know that transporting post-ROSC is some of the riskiest things that you can do for a patient during, well, and really just transportation, right? It's because I want to make sure that I'm supporting my patient, because I can get ROSC, you know what I mean? But am I getting sustainable ROSC? And again, we can go and you can go watch my video. I have a whole thing about, you know, what I feel ROSC is, how long we should be, you know, sitting with it, all of that stuff. But to the point of EMS Avengers, you know, am I there for resuscitation or am I there for a death ritual? Now, what constitutes a death ritual? A death ritual legitimately can be almost anything, right? So it can be that this is what I consistently do every time that I work with somebody who is dead, not dead, but dying, right? And ultimately, yeah, we kind of are naturally performing a death ritual, because for us, it is ritualistic, right? We follow these ACLS guidelines that say you should be doing this, this, and this. You should be giving this, this, and this. But unfortunately, we are not working as a group thinking about the current patient. We're working as a group thinking about our algorithm. And guess what? Our algorithm is really not meant for pre-hospital emergency medicine. Our algorithm is kind of really meant for hospitalists, and we are not hospitalists. We are pre-hospitalists. And because, you know, we are not governed by the same level of people that are, you know, governing other types of medicine, really. And within the last 20 years, we really even just kind of like got acknowledged in the emergency medicine world as being a very important piece of emergency medicine, because they're finding that what we do pre-hospitally absolutely affects patient outcome. But, you know, and obviously there'll be people that are like, well, we've known this for years. I'm sure you did. Not everybody did. And honestly, most people didn't even acknowledge it. Like, we're still governed by the transportation division. So you really want to get into it, friend, let's go. But outside of that, right, like we need to be treating these patients based off of the patient presentation, based off of what we know about that patient in the time frame that we know about them, and then working the algorithm, but also making sure that we're utilizing outside drugs within our scope of practice and what we have available to us to best support these patients long term. I'm going to turn off the video because it's already getting long, and I have a feeling it's going to delete it if it gets any longer, but I could go on for hours. So yeah, go watch the video from EMS Avenger. It's good.